Hey everyone, so I wanted to do a video on discharge planning. So if you saw my last video, you know that there was a new position offered to my department and I was interested in it. So I told them I was interested, and the big news is that I will be doing this new position soon. And because of that, I am no longer going to be doing discharge planning. I'm going to be doing just insurance reviews. So because of that, I wanted to do a video of everything that I can think to blurt out about discharge planning for you guys. And if you hear a buzzing noise, it's my pump. I'm pumping. I was hoping to have more time today to chat with you guys, but it's been busy. I swear to God that like someone is punishing me, like just the universe, because I'm going to be done this role and not doing discharge planning. So I feel like it's making sure that the discharge planning that I have been doing ever since I knew that I was going to pick this role or do this role has just been so hard, so difficult. So I am still doing, this normal role for a few more days. So I figured that over the next couple days, I would pop on here as I think about things to say and tell you as much as I can about discharge planning. So to start off, discharge planning starts the moment that you walk in the hospital. So, or I guess admitted to the hospital, not specifically walk in, but the moment you're admitted to the hospital. And there are usually case managers in the emergency room. They may not get to every single patient before they end up to the floor, but if at all possible, then the case manager is seeing the patient downstairs. I'm sure every hospital is different and they do things differently, but for our case management department at our hospital, when a patient is seen, we do what's called like a discharge planning assessment, which mostly revolves around their prior level of function and like their prior living situation. So what does their house look like? Who do they live with? How do they move around usually? What equipment do they have or use? Do they have a primary doctor? Do they see their primary doctor? Do they need a new one? How are they picking up their medications? Can they drive? Can someone else drive? Can they afford their medications? Do they have any social barriers like, money insecurities, food insecurities, housing insecurities, any, domestic abuse, violence, improper living situations, hoarding, their electric's not on because they can't afford it, bug infestations, things like that. So majority of people who come in, have stable living environments and are just able to kind of go home, or still have stable environments, but maybe they need to go to rehab for a little bit. And then some patients come in and they may have a stable living environment, but they're elderly, they're not going to be able to return home. So you have conversations with them and the family about kind of next steps, nursing homes, assisted living, selling homes, things like that. And then sometimes you have situations where their home is just not stable at all. And this can be people who are young, middle-aged, older population, and we do the best that we can to help those people. We do not have magic wands. A lot of people will go back to living in environments that, maybe we don't think are the best. Patients have the right to make decisions no matter how bad we think they are. So we're not going to force anyone out of their home. We don't force anyone to go to rehab. We can't force anyone to get drug or, mental health resources, such as like rehab and things like that, unless they're like needing to be like involuntarily committed to like a psych unit or something. That's completely different, but that's not even us. So that's kind of what you're just getting a feel for with the discharge planning assessment. Like, what were they like prior to coming in? And then once they are medically ready, which you have daily meetings with the doctors, usually like twice a day, to kind of talk about what's going on with them medically. And we are usually working on discharge planning along the way. So the way that we do that is we're looking at nursing notes, seeing if they're ambulating, walking with the nurses. If they're not, you know, we really need to get physical therapy, occupational therapy in there. If they're at a certain age, we almost do that just like automatically no matter what, because we want to make sure that our 70, 80-year-old, you know, and even 90, obviously, year old people are doing well and able to go home, because they can be so fragile that just a day or two sitting in bed in the hospital can really hurt their mobility and their strength. So we're following nursing notes, we're following physical therapy and occupational therapy notes, we're recommending that the doctor order physical and occupational therapy, we're talking to the patients at bedside, calling them on the phone, we are talking to family members, making sure that they are all kind of in, you know, the know about what the patient's plan is going to be at discharge. So once the doctor actually says the patient is ready for discharge, ideally they go. In an ideal world, they would just go. So like prior to knowing that the patient is ready for discharge, we are supposed to know, is that back home with no services? Is that back home with home health? And if so, home health ideally would be arranged already. And is it outpatient physical therapy that they need, outpatient speech therapy? We have a nurse that will make outpatient appointments for people, primary doctor's appointments, specialty appointments. So we do usually communicate with her as well if we need something for her to order. Then if they cannot go home, we usually know, you know, beforehand that they may need rehab. So prior to even knowing that they were ready for discharge, we're sending referrals to facilities. You always have to talk with the patient first, and or their family if that's what they want, but talk with them first, give them a list of facilities so that they can choose which one that they would prefer to go to. Send the referrals. We check to see if they are on par with their insurance. We check to see if the facility, you know, has a bed for these people, and always try to get their preference first. And if we're not able to, then we kind of move on and let them know what is available. And then ideally they still do, you know, hopefully pick. It may not be their preference, but we really do want them to tell us, you know, where they're willing to go. And they can't just not go if their preferred facility does not have a bed for them or would not accept them for some reason, such as insurance, or, you know, they don't really like, I mean, realistically, the facilities can deny patients just based off their notes, and if it's a patient that they don't feel like they can care for some reason. So guidelines for insurance usually are you go with the first available facility that's appropriate for the patient. So that's why they don't really get to just like hang out here waiting for their like preferred facility to accept them. They have to kind of go, if their preferred facility can't accept them, they have to go with what there is to offer. So there's all kinds of different kinds of rehab. There's acute rehab hospitals, which you still see like a doctor 5 days a week, and you get physical therapy and occupational therapy. You can get speech therapy. They are an accredited hospital, so they still do some of the hospital things that, you know, are done in your typical hospital. Not everything, but, you know, they can kind of take care of more complex patients. And then there's skilled nursing facility or subacute rehabs. Those are your nursing homes. Ideally, the nursing homes have separate wings from people who are there for rehab and people who are there long-term. That's not necessarily the case since COVID kind of happened. Sometimes they are kind of in one and the same, but, you know, that's not something that we have control over. So you don't really see a doctor that much while you're there, only kind of as needed. They do have to evaluate you when you get there, but, you know, you have a nurse and things like that, and physical therapy and occupational therapy, and it's not as much as you would get at an acute rehab hospital. And I've found out by living here, where we have 2 acute rehab hospitals, that not everywhere has that higher level, you know, oversight kind of acute rehab hospital. People come from over an hour from here to go to our acute rehab hospitals. So it's kind of interesting. And there is also long-term acute cares, which can be called like an LTAC. And that is like, they're literally usually like in a hospital. Like we have one like on our higher level floor, and they're not at all like associated with our company or anything like that. They're completely different owned. They're not affiliated with us either in any way, but they're usually in hospitals because it's like a long-term acute care hospital. People are usually there like much longer, like maybe on average 30 days. And it's just for those really complex patients. So not only do they get their rehab, their physical therapy, their occupational therapy, they can get speech therapy, but they also see a doctor like 7 days a week. They can go for surgeries if they need to. They can literally do anything that we can do here in the hospital, except for like if you're decompensating and need like actual acute hospital care, they would transfer you back to the hospital. But as long as you're stable, I mean, like nephrology can see you up there, surgery, infectious disease, orthopedics. It just depends on like what services they have available. But you'll see like a doctor still 7 days a week, and any specialty that, you know, they have that you need, and you'll get like all your care there. So that's for like really complex patients, maybe people who were in the ICU and are maybe ready to move on, but are still very medically complex. So that is kind of what you're looking at for rehab. And then we help people with like drug problems get into alcoholic rehab if they need, get them services outpatient such as, you know, AA or an intensive outpatient program. So yeah, it's pretty much people go home, they go home with nothing, they go home with outpatient therapy, they go home with home health, any outpatient resources that they need, or they go to rehab of some sort. And we help with that. Patients can also be transferred from one hospital to another. It's like usually a transfer to like a higher level hospital. Like our hospital is not like one of your like huge hospitals that like have trauma certifications and things like that. We are like a smaller community hospital, so there are things that we can't do here. So patients could be transferred from our hospital to like another hospital. And our case management department really doesn't help with that. We just kind of follow along in the chart and see if anyone needs anything from us, but that's usually doctor and nursing driven, like everything up into transportation. So transportation is another thing. Often when people go home, they have their own transportation. If they are going home and they don't have transportation, we can give them a bus pass for free. And other than that, you know, we can set up transport, but they have to pay for it. So some hospitals have their own transportation services where they'll take people home. Our hospital does not have that. We don't have a medical Uber that we pay for. We don't have, you know, like a company that we partner with that we pay for. Like, you know, really, it's like if you can't take the bus, you know, you really do either have to find your own ride or pay for like a wheelchair van, a taxi. You know, you can get your own Uber, but we're there to just kind of let you know what the options are. If you're going to rehab, we can help get, you know, you can always be transported in a car if you're able to, but we do arrange often like wheelchair vans and ambulance rides for people to go to rehabs. Wheelchair vans are not usually covered by insurance, and then the ambulances are billed to insurance, and we do a form that tries to say why it's medically necessary, and that is all submitted, and then it's up to the insurance on the back end to decide if they're paying and how much they're paying. So that's kind of out of our hands, but we do help often with transportation. So I am done pumping and I gotta go back to work, busy day. And I just wanted to tell you as much as I can about discharge planning. So I will get on here and tell you more as I can. I'm sure I have more, and I am so excited to move into this new role. I am gonna make a video all about utilization review, which is what I will be doing in this new role. But I wanted to make sure that for anyone who is interested in case management and discharge planning kind of gets a feel, and that I give you as much information as I can about discharge planning before I am kind of done with that, and you won't really be hearing much about that again from me. So I'm more than willing to answer any questions that you have. And I wanted to tell you guys that I found this new place to pump. So I'm only pumping one time a day, or one time at work now. I'm pumping 3 times a day instead of 4, and now 1 of those times is at work versus where it was 2 before. I'm gonna be on a different floor for this new role, kind of like in an office type area, and there's this like lounge where like I guess people have kind of like meetings with patients and visitors, and yeah, I came in here and said it's on the same floor as the floor that I will be on in my new role, and it's private, it's secluded, it's good lighting, it's comfortable, tables, chairs, so I'm gonna pump here, I think, as much as I can. All right, let's get out of here. Hey guys, again, if you're hearing any buzzing, it's because I'm pumping, and I have to tell you that I am so close to being done pumping. My daughter just has a few more months until she is 1 year old, and I don't even know that I am gonna be pumping that long. So once I decide that I'm done, which is gonna be soon, then I am just gonna be so relieved that I do not have to do that anymore. I already beat the time frame that I pumped with my oldest daughter. I did 10 months with her, and I am at like 11 months-ish. It's less than that, but ish with my youngest. So we'll see how long I do it. I'm gonna do it for as long as I want to and can tolerate it, and then I'm just gonna stop. We're already having to supplement with formula now within like the past week. We've used formula before, like on vacations and stuff, just to make it easier, but we are like pretty much officially out of my freezer stock and are now supplementing with formula, and then we're just gonna kind of slowly transition to formula, and then we'll feed her that for the next couple months until we'll eventually transition her over to oat milk when she's like 1 year old. We did that with Olivia, you know, we're gonna do that again. Olivia loved the oat milk. We love the oat milk. We buy that anyway. So we're just gonna do that. So I thought of plenty of other discharge planning topics that I thought that we could talk about. Oh, by the way, it's the next day, clearly, different outfit. I wanted to just kind of reinforce how much goes into discharging someone to rehab. So, you know, if I'm starting the process, I have to speak with the patient, family, facilities, find a bed. If I'm doing the insurance authorization, I have to call the insurance. I have to start the insurance authorization. Some do it by portal, but again, you have to get on the website and start the insurance authorization, which usually involves putting in a bunch of information about the patient, the insurance, the place that they're going, our facility that they're at now, and then sending clinical information. So notes like from the doctor, notes from physical therapy, occupational therapy, kind of saying why they need the rehab. And then we wait for the insurance to get back to us, and that can be anywhere from like 4 hours to a day. We've seen it be longer, like 2 days. So it just depends. Once we get the insurance authorization back, which is the case for the patients that I had yesterday, then you have to tell the patient, tell the family, figure out transportation. If it's something that you have to arrange, then you have to arrange the transportation. Once you arrange the transportation, you have to tell the doctor, the nurses, the patient, the family. You have to make sure that any medications that they need that the facility can't get, they bring with them. Any CPAPs, BiPAPs go with them. Make sure that they have clothes to go with them. So it's just a lot. And let me tell you, you get called in the room multiple times to kind of give the patient and the family updates or answer their questions. So that is kind of what, oh, and then there are forms. I wanted to mention that too. So anytime that someone is discharged and they have like a Medicare plan, so that can be anyone over the age of 65 or anyone that has had a disability for 2 or more years and has been on disability for like 2 or more years. So, and like applied for that process, I assume it's like an application. But anyway, so you don't have to specifically be 65. You can be someone who is disabled and have Medicare, but they have forms that you have to give prior to discharge. It's called an important message from Medicare. They have the right to appeal their discharge if they don't believe that they are medically ready. And we do have patients that do that. And what happens then, if they appeal their discharge, then we send clinical information to, they have to call this number, which notifies, you know, whatever party, you know, is associated with Medicare. I mean, I'm not going to get into like the exacts because, I mean, I know the names, but you guys don't really need to know the names. But they contact those people, let them know that the patient has to call them, notify them that they're appealing their discharge. They get in contact with our hospital, let us know. We send the entire chart. So every single piece of medical information from the admission goes to them, and then they usually get back within 24 hours with a determination on whether they agree with the patient or agree with the hospital. If they agree with the hospital that the patient should be discharged, and all the information's in there on like where we're trying to discharge them to, if they agree with it, then the patient has 24 hours from then to actually leave the hospital, or the bill will start to accrue in their name. So the insurance will be done paying at that moment. So, you know, included in discharge planning is forms. There are also forms that need to be given to certain patients when they are kept in the hospital. These forms are called observation forms. I've mentioned that you can be in the hospital under different statuses. You can be in inpatient, which is what most people think they are in the hospital under. Observation, which is like an outpatient like order, really, like it's like you're staying in the hospital but you're being billed as outpatient. That's for people who like maybe we don't have like a really strong diagnosis for you. Maybe we don't know that it's a stroke, or we don't know it's a heart attack, or you know, your symptoms are kind of vague, but definitely warrant you staying in the hospital. Like, you know, it could be life-threatening if you go home and it is something serious. So let's say we're doing tests, blood tests, we're doing imaging, you know, obviously like checking you, like your assessment, like with the nurse and the doctor. So they may keep you under observation. And then you can also be in the hospital as an outpatient extended like surgery, which is usually something that is prior auth or pre-approved or whatever through your insurance prior to the surgery. It's usually something that you know about that you're having. Those are also technically kind of like outpatient, but you're in the hospital, which is confusing. So if you're in the hospital as observation, then you need an observation form, and it's just letting you know that you're in observation. It kind of explains it a little bit more, and the signature just kind of lets them know that we talked about it. It's really confusing for patients because they're in the hospital, they have a bed, they don't really understand what it means to be in the hospital as observation. And to be honest, I mean, it's kind of silly in my opinion as well. I mean, I get why they do it, but it's definitely a cost thing. It's to save insurance's money. I don't know. It's not something that I came up with. I just have to give the form. So forms at discharge for certain patients, forms on admission for certain patients, and that is pretty much everything I think that goes into a discharge. Discharges for patients who go home. You know, I already talked about some of the services that they may need, like home health, outpatient therapy. Some also need equipment such as like walkers, wheelchairs, crutches, canes, bedside commodes, shower chairs. Insurances don't always approve equipment once you enter into the bathroom. So shower chairs, over the toilet seat risers, those bars, that kind of grab bars to help people get up. Those are not something that's usually covered by insurances. We can always check. Commercial insurances are different. Medicaid insurance can be different, but in general, that is something that's not covered. I think Medicaid does cover certain things in the bathroom, but not everyone has Medicaid. That's like your county or your state insurance, and for like low income people. So we make sure that the patients have any equipment that they need to go home. We make sure that they have any services that they need. We make sure that they have a primary doctor, like a PCP, primary care provider. A lot of patients come into the hospital and they do not have one of those for whatever reason. Maybe there's left, maybe they have moved recently, maybe they're just someone who has been healthy and hasn't needed one. Maybe they just recently got their insurance. So we have lists that we give to people. Really, we again try to empower our patients. So it really is on them to pick a primary doctor and make the appointment. I'll give the list, and then if they pick one prior to leaving, then that nurse ally I was talking about, they can make the appointments for patients. She'll also make some specialty appointments for people just based off of their situation, and if that is something that they feel like is gonna help the patient, you know, if they feel like the patient's not able to do that or is not going to do it. Kind of going back to some of like the insurance things. So if you didn't know, there's different kinds of insurances. There's Medicare, which is usually for people that are 65 and older or have been disabled. There's Medicaid, which is like your low income state funded insurance. There is commercial insurance, which is going to be your insurances that you get through your employers, or insurances that you get like off some sort of like marketplace or whatever. But that you're just like kind of paying privately for. And then there's like VA insurance for veterans, and there is cost sharing plans. So they're usually like religious cost sharing plans. Now the cost sharing plans and the VA, they'll say things like we're not insurance, and like we're just like a healthcare plan or a healthcare system or whatever. So the VA, I mean, that's different. They definitely cover their veterans and things like that. But the cost sharing plans, it's like a pool of money. So you're paying, they still have like the same kind of things, like regular insurance has premiums that you pay every month. They still have that, but it's called something different. They have deductibles, which is usually the amount of money you need to pay until your insurance starts to pay like a higher percent of things. And they have that, but it's usually, again, called something different. And then a maximum out of pocket is usually like what your insurance, you have to pay until your insurance pays 100% of things for you. And they have that as well, but again, it's called something else. And my understanding is it's like everyone that's in this cost sharing plan pays their premiums every month, and then it acts exactly like insurance, but they're called things different. And honestly, people don't really recognize them as insurance. It just depends. Like I've had difficulty getting patient services with those things, but I mean, it does help them. I've had people who have needed things. It may have taken a little bit longer, may have been more difficult for them, you know, but I'm usually able to get them what they need, and it's obviously not them paying 100% for their needs. So knowing the different kinds of insurances and what you need to do. Oh, there's also workers' comp, like people who have been injured on the job and now their workers' comp is covering things. So just knowing like what insurance your patients have. Obviously there's plenty of patients who have no insurance. So knowing what's going on with their insurance, or if they don't have any, is so important. Certain companies for home health, rehab, equipment, take or don't take certain insurances. Certain insurances cover things that others do not. Some have higher co-pays than others. When you're working with someone with the VA, you have to go through the VA for everything. They're the ones that have to give you the approval, which obviously takes a little bit longer. That's the same for like the cost sharing plans. They have like, you have to go through the cost sharing plan in order to get anything arranged and approved. And then workers' comp, they usually have like an adjuster that's been assigned. And then you have to get everything that the patient needs kind of approved by them. And it just takes a little bit longer. Like if you have typical like Medicare or Medicaid or commercial, those are going to be your most common, and you don't really need to get approvals for things like home health, DME, which is like equipment, like outpatient therapy. Really the only thing you need to get approval for is going to be your rehabs, but you don't have to get approval for like those other things. So if a company accepts the insurance and they know that it's on the formulary for the equipment or home health or whatever, then you can just like get that service in place and send them home. So it's a little bit quicker than your average, and those are the most common insurances that people have. So that's what I deal with more than usual. So my pump just hit 15 minutes. I'm gonna unhook and I'm gonna look at my list of things that I wrote down for discharge planning and see what else I can talk to you guys about after work, or after I have a little bit more time to talk to you. Alright guys, another day that I finished, one step closer to starting my new job, and I thought of a few things I wanted to add to the conversation from earlier. So when there are forms, there is also this form we do for anyone going to a nursing home, and not for long term. I mean, you do need it for long term as well, but if they're even just going to rehab, and it is a form called a PASSR. I am not going to tell you what it stands for. Look it up if you want to know, but it's really like a form that we complete to make sure that the patients are actually like appropriate to go to like a nursing home. And there's certain diagnoses on there, like it can be neurocognitive, seizures, psych, drug related, that can make you what's considered a target on the PASSR. And that means that Area Agency on Aging has to do like a level 2 assessment. It goes to like the state. They're the ones that actually like complete it. I think it just kind of goes through Area Agency on Aging, and it has to be decided, approved, that they're okay to go to the nursing home for their rehab or long-term, either one. I think it's just like a protection to make sure patients aren't being wrongfully placed in nursing homes. I don't know exactly, but I do it, and that is something I thought about for forms. I mentioned patients being uninsured. We do help them see if they qualify. This is not us exactly, this is the hospital. We have like a contracted agency that actually does this for us, but they'll come in and see if the patients qualify for Medicaid. If they think that they do, they'll help them apply. Medicaid is backdated, so if they do get approved, then their hospital stay will be covered. They also have ways of like trying to get the hospital covered for, you know, other people too, but I don't know exactly what they do. But we, like case management, does have resources for patients who are uninsured. Like there is a clinic for uninsured patients in the area. We can get them in there, or at least give them the information. We have like GoodRx for getting their prescription coverage to be, you know, cheaper, but ultimately we do not have any kind of magic wand. So if you don't have insurance and, you know, your Medicaid is not going to come in like that day that you're at the hospital, so if you need anything to go home, it really is going to be on you or them, whatever, to get that stuff by their own money. So we'll see what discharge planning holds for us tomorrow. I am hoping to be able to empty out my cabinets and my desk stuff tomorrow and start, just at least put it in a box and start moving it, put like the box and everything at least down. New desk is gonna be, so we'll see what discharge planning holds for us tomorrow, and then I will make sure that I pop on here and let you guys know. Bye. Guys, I'm a hot mess. It's Friday. It's busy. It's been busy like this whole week and the previous weeks. Like I said, I feel like the universe is punishing me for leaving and not doing discharge planning, because discharge planning has been so difficult. I look a mess. I should have showered last night and I was so tired. I fell asleep. I was snuggling my youngest and just fell asleep with her. Did not wake up until like 4 o'clock in the morning. And so I didn't shower. Went back to sleep at 4 and didn't wake up till like, you know, probably later than I should have. So I couldn't even shower in the morning. So I feel like I haven't showered. My hair is dirty. I have a bug bite right here that just showed up and I was itching it, so it's all red. It is like pretty much the end of the day. I think it's literally almost 5 o'clock and I'm pumping now, which is late. I usually pump at 3, but I should pretty much have just like everything done. Maybe just a few things to tie up before I go today. And it's my last day on the floor as a nurse case manager doing discharge planning. So I, you know, had watched my videos back and thought of a few more things to talk to you guys about that I haven't yet. And I'm sure I'm missing things, but I do feel like I talked about a lot. So when I was talking about people who are uninsured, I forgot to mention that there are equipment donation places that give you equipment for free because they were donated from someone else. There is one near us, but it is like about a 25-30 minute drive from here. And I don't know if people are like this where you live, but the people where I live, they don't want to drive very far. So a lot of people don't see that as like a real option because it's 25-30 minutes away. But I mean, if you are uninsured and you don't want to pay the $100 and some it is for crutches or a walker or a bedside commode, I mean, you can probably get those things for free at these places that donate. I mean, wheelchairs, I believe they have those as well. I mean, it just depends. You would have to call and see if they have it. So some people do utilize that if they're serious and they need the equipment and they don't want to pay out of pocket. And I always recommend, you know, for equipment, people also go to like Goodwills and Salvation Armies and other like secondhand stores, because they'll have, I've seen like brand new wheelchairs for like $15-20, and those things are expensive. I mean, they can be $100, $200, $300 depending on what kind of wheelchair it is or what, you know, kind of wheelchair you're trying to get. You can get crutches for like pennies on the dollar. You can get walkers usually. shower chairs, things like that. So I always recommend that. A topic that I completely forgot to bring up is hospice. We help people go home on hospice, go to a nursing facility on hospice. Our area does have a couple hospice homes, one that is kind of like income based. So if you don't make a lot of money to pay privately, then they do payment based on a sliding scale. So that's a potential if they have a bed. There are other hospice houses that the pay is a hospice house where you're just going for your comfort measures, like you don't have acute needs going on, like you're not requiring interventions related to pain or agitation or shortness of breath. So if it's purely maintaining your comfort, insurance, at least in this area, doesn't pay for that. So there are some hospice houses for that you do have to pay privately for, and they are relatively expensive. But people who have money do go there. We do help people go there. Like I said, we have the one hospice house that is a sliding scale, and then nursing homes, you can have hospice in a nursing home. And if you cannot afford to go to a nursing home and pay privately, which in this area is anywhere from $10,000 to $13,000 per month, then you can apply for Medicaid. And if you qualify for Medicaid, then they will cover the room and board. And that's not just for hospice patients, that's for long-term care patients too. So if you come into the hospital and you're not able to go home for any reason and you have to be placed in a nursing home long-term, again, it's about $10,000, $13,000 per month. And if you can't afford it, then you can apply for Medicaid. If you apply for Medicaid and you don't qualify, there's usually some sort of financial reason, and you do have to spend down your money until you were to qualify, and then they can pay for your room and board. If you're going to a nursing home in general for what they call custodial care, so you're not there for skilled nursing, you're not there for skilled physical therapy or occupational therapy, you're just there for like the nursing care to kind of help you live, do your activities of daily living, showering, dressing, walking, eating. Insurance usually does not pay for that. So that's where that private pay cost comes in, or trying to get Medicaid. That's like long-term, but as well as hospice. I mean, hospice can be long-term as well, because it really is for the rest of your life. So hospice at home, setting up hospice agencies that come into the home, they do not care for you round the clock. So a lot of the burden does still fall on family, but they are there for support. They do offer nursing services for bathing, usually 5 days a week. They do social services, chaplain services, and then obviously your skilled RN to help with like pain management and stuff like that. Insurance does usually pay for that. There are acute hospice like wings or acute hospice houses, and that's for your patients who their symptoms are not managed. So they're maybe actively dying and they're short of breath and we're having trouble managing it, or they're in pain and we're having trouble managing it. Then you may qualify to go to one of these inpatient hospice houses, and that is covered by insurance for as long as those symptoms are not managed. Once they're managed, they're going to be looking at discharging, whether that's to home, to a nursing home, to one of these other hospice houses that are private pay or the sliding scale. So we do help with hospice. They also have hospice people that stay right here in the hospital. You have to meet certain criteria. It's called GIP, which is like general inpatient hospice. Like, you have to meet certain qualifications. So again, your symptoms need to not be managed. We're managing it. It's usually a hospice agency is also coming in, trying to help us manage things. They're seeing you every day, assessing you and making recommendations. And then those are usually people that are imminently dying, and they do usually pass here at the hospital. If at any point their symptoms are managed and they're really not actively dying, and there's time to do discharge planning and get them onto another level, whether that be home or a facility, then we will help with that. We also do psych placements. We don't ourselves really do the psych placements, but we help facilitate it. So let's say a psych provider sees a patient who is in for some sort of psych reason, and they are deemed either a 302 or a 201, which I'm sure those vary. I'm sure those numbers vary depending on where you live. But a 302 is like you have been involuntarily committed. You have to go to a psych facility and you have no option but to go. You cannot refuse. You cannot leave against medical advice. And then there is a 201, which is voluntary. So they have assessed you. They say, yep, you were qualified to go, but you are choosing to go voluntarily. And at any moment, you can decide you don't want to go, and then you can be discharged. So if you are 302 or 201 and you need to go to a psych facility, we have like a crisis line that we call. These crisis workers will come in, assess the patient, make sure the 302 and the 201 are done, and then they will start the psych bed search. So they actually do the bed search, and once there's a bed, they kind of arrange all of it. What we do usually is communicate with them daily, try to see where they are in their bed search, let them tell us if anyone is interested and what they may need clinical wise, whether they need labs, notes, or anything like that to, you know, further, you know, hopefully confirm a bed and get a patient there. They set up any kind of transportation for them to go. I think I said this earlier in the videos, but like we do help with getting people like into drug rehab. There's usually reps. There is programs out there that are like drug addicts and things like that are now recovered, and they help people get into programs. So we communicate with them, try to get people in places. We know of places. If the patient wants to go, we contact them, try to get them in. We help them with like AA meetings, outpatient, if that's what they want, an intensive outpatient program. We help people get resources on, you know, their mental health. So getting them usually just information on seeing a psychiatrist or a counselor, outpatient, or getting into like a drug treatment program or halfway houses, like I said, AA meetings, whatever the patient needs. We are really the person that connects them to the resources. A lot of the time, if it's like an outpatient thing, they need to make their own appointments. They need to get themselves into these programs, but they can use us as a resource to find out what these things are. I very briefly at some point mentioned that we help with like violence, like domestic violence, and that's really a social worker thing. I will pull my social worker if they need, like if there's allegations or there are suspicions of a domestic abuse situation, because that is just not something that I'm educated in, and they will usually see the patients for me and then get them access to whatever resources that they need. A lot of them do just end up going home, and we make sure they have everything, all the phone numbers that they need in case they need to leave that situation. And we do help assist with the organizations that are out there in placing people in like safe housing if they have to go there straight from the hospital and they can't go home. A case management role that is not at all something that I do is labor and delivery. We do have a case manager over there that helps, you know, anyone that is needed for a safe discharge plan from the hospital when they have a baby. Most moms come in, have everything that they need, and they go home, and they knew they were pregnant. They have the support that they need, so they go home with no needs. But you know, from time to time you get that woman who didn't maybe know that they were pregnant, which absolutely does happen. They didn't have anything for the baby, so we just help connect them to resources, make sure that they have the support that they need. We have teen pregnancies. We have moms who are on drugs, or maybe used to be drug addicts and now they're on like some sort of drug medication treatment plan, and we just support them and make sure that they have everything they need to be successful taking their baby home. You know, low income, we help make sure they have a safe sleeping space, like a pack and play, car seats, things like that. So that's labor and delivery. And adoptions as well in labor and delivery. I forgot to mention that, like we help with all adoptions. So if it's someone giving their baby up for adoption or an adoption that came in and it was like planned. We help facilitate that and do paperwork. So we do have like a NICU, so our social worker helps with any discharge planning needs from the NICU, offering support, counseling, things like that. And that's really all I can think of. And I'm sure, like I said, that I missed anything. I hope that I went over as much as I possibly can about discharge planning, gave you any information that you wanted. I am available in the comments to answer any further questions, and I will definitely be posting more videos about my job. If you are interested in following a girl in her 30s who is a nurse, a case manager, working outside the home, I have 2 kids, I post lifestyle, work motivation videos, so please consider subscribing if this is something that you're interested in, and I will see you guys in the next one. Bye. I would have talked to you walking out to my car, but let me show you. I had to carry so much stuff. I had a cake and a balloon. So cake is here. Balloon says feel better soon, which is hilarious. A physician assistant got it for me because he knew today was my last day, and those are the only types of balloons that the hospital has. Who knows where he got the cake? Honestly, he got it in like a few hours. So it even said Brie on it, which is hilarious. So nice of him to do. It's like 6:30 right now. I took everything out of my desk, took it downstairs, put it in my new desk, organized things as quickly as possible, nothing major. And I don't have that much stuff either, but that's what I did. And it's just interesting because I'm seeing the nurses and stuff like coming in for change of shift, and it's getting darker. It's like that time of year where it just starts to get darker earlier, and it's going to start doing that, I'm assuming, more and more. But it's like darker than usual. The lights are coming on. It's just it's a weird feeling. I used to be a night shift nurse at bedside, so I do not envy those girls at all, and it's just kind of bringing back some nostalgia. You know, I started as a nurse on a step down respiratory ventilator floor, and now I'm going to transition into a job where I really don't do any patient care. And honestly, my career has kind of moved towards that more and more and more. I do want to do a video just kind of talking about my progression in my career and how I got to where I am today. So if that is something that you want to watch, let me know down below in the comments. I will definitely make the video regardless. Yeah, check it out when it comes out. I don't know when that will be, but I have definitely thought about making that. I hope you enjoyed this video and learned all that you can learn about discharge planning. It was really a fun video to make. I like to chat. It was a chatty video, and ask me anything that I may have missed in the comments.